Welcome back to the chapter on nephrology. In section 4, we will be talking about the endocrine functions of the kidney. So let's get started. So here is a list of the hormones that relate to the kidneys. We have prostaglandins, dopamine, and bradykinin, and we will spend some time explaining the relevance of these three hormones. As for vitamin D and PTH, these are explained in great detail in the section on calcium homeostasis in the endocrine chapter, so we won't spend any time talking about them here in this lecture. Also, we have the atrial natriuretic peptide, and the last hormones we will discuss are the renin, angiotensin, and aldosterone system, and then finally ADH. So let's start with prostaglandins. When released into the blood, they dilate the afferent arterioles. And as you recall from section 2 in the nephrology chapter, talking about equations, if you dilate the afferent arteriole, you will have more blood flowing through the arterioles, so renal blood flow will increase. And more blood will be filtered from the glomerulus into the urine, so GFR will increase. As a pharmacological tie-in, NSAIDs will block prostaglandin synthesis by inhibiting COX-1 and COX-2. So now let's do a quick practice question. What would meloxicam do to the GFR? So we'll write meloxicam. Well, recall that cyclooxygenase enzymes are responsible for synthesizing prostaglandins. And meloxicam is an NSAID. And as with all NSAIDs, meloxicam will inhibit the cyclooxygenase enzymes. And this will result in a decrease in prostaglandin synthesis. So let's draw a quick glomerulus with an afferent arteriole, the Bowman space leading to the rest of the nephron. Recall that prostaglandins normally dilate the afferent arteriole. So decreased prostaglandin synthesis would result in a relative vasoconstriction of the afferent arteriole. So this would lead to decreased GFR. Now let's talk about dopamine. So dopamine is secreted by the proximal convoluted tubule, and it can be administered and it can come from other areas. And what it does is it will dilate the afferent and the efferent arterioles, and this will increase the renal blood flow. And it's important to know that this occurs at a low dose, because at a higher dose, dopamine will actually cause constriction of the vessels. So let's do a quick question. So first we're going to draw out a glomerulus, the Bowman space, and that would lead to the rest of the nephron. So if a patient was administered a low dose of dopamine, what would this do to the GFR? Draw an A here, E here. Dopamine will dilate the afferent and the efferent arteriole. And this will allow more blood to flow through the kidney. However, since the efferent arteriole isn't constricted more than the afferent, you will not have an increase in GFR. So, if a low dose of dopamine is administered, GFR will be unchanged. Moving on to bradykinin. With reference to the kidney, bradykinin dilates the arterioles. The next thing you need to know is that bradykinin is broken down by the angiotensin converting enzyme. So, bradykinin will dilate the arterioles, which will increase the renal blood flow, RBF. An angiotensin converting enzyme will actually break down bradykinin. So let's do a quick question. What will an ACE inhibitor do to the renal blood flow? Well, an ACE inhibitor would block the angiotensin converting enzyme and decrease the amount of bradykinin that is broken down, and therefore increase the amount of bradykinin in the serum. So arterial dilation would increase and renal blood flow would increase as well. Now it's important to recognize that the ACE inhibitor did not increase GFR. Recall that the angiotensin converting enzyme leads to increased levels of angiotensin II, which preferentially constricts the efferent arteriole. And if you preferentially constrict the efferent arteriole, you're going to increase GFR. So, with the presence of an ACE inhibitor, angiotensin II levels will be decreased and GFR will be decreased as well. So with the presence of an ACE inhibitor, angiotensin II levels will decrease and so will GFR, but renal blood flow will increase. Bradykinin is discussed also in section 6 in the pulmonology chapter. Next, let's talk about atrial natriuretic peptide, or ANP. This is a hormone released from the atria in response to increased volume in the atria of the heart. Increased volume in the heart can act as a surrogate for overall body volume. The job of ANP would be to decrease that fluid volume. So once released, ANP goes to dilate the afferent arteriole and constrict the efferent arteriole. So let's draw a glomerulus. Got the Bowman space, which leads to the rest of the nephron. We'll draw an A for afferent here, an E for efferent here. So if ANP is dilating the afferent arteriole but constricting the efferent arteriole, more blood will be filtered from the glomerulus into the urine. So GFR will increase, as written here in your text. This increased fluid flow will act to decrease renin release. As we jump into the renin-angiotensin-aldosterone system, which is on the next slide, this will make more sense. Now let's talk about the renin-angiotensin-aldosterone system. You'll often see RAS as a short acronym. As a brief overview, the juxtaglomerular cells will secrete renin in response to certain stimuli, which we will talk about later. Renin then converts angiotensinogen into angiotensin 1. And angiotensinogen is actually released from the liver. Angiotensin converting enzyme, or ACE, which is produced in the pulmonary vasculature, then converts the angiotensin 1 to angiotensin 2. Angiotensin 2 then acts on the nephron to increase GFR. Angiotensin 2 also increases aldosterone secretion from the adrenal glands. Aldosterone then acts to increase fluid return from the nephron. So the whole goal of the renin-angiotensin-aldosterone system is to increase blood pressure and fluid volume. So let's draw this out on the next slide. To explain the renin-angiotensin-aldosterone system, we need to start at the beginning, the juxtaglomerular apparatus, or JGA. Here is an image of the juxtaglomerular apparatus. Here's the afferent arteriole, the efferent arteriole. Then we have the Bowman space leading to the proximal convoluted tubule, then the loop of Henle, I'll just write loop, and then the distal convoluted tubule comes up, write DCT, and that is between the two arterioles. Within the distal tubule, there are macula densa cells. So we'll draw these here, and we'll just write MD for macula densa. And we'll describe these more in a minute. And finally, we have the juxtaglomerular cells, right here, JG cells. In the previous slide, we discussed that these juxtaglomerular cells secrete renin in response to certain stimuli. So let's explain what these stimuli are. First, if the blood pressure coming into the afferent arteriole is low, then the juxtaglomerular cells will secrete renin here to try to overcome that low fluid volume. The second stimulus is low sodium and chloride flowing through the macula densa, and let's describe why. So if less blood is being filtered from the glomerulus, causing a decreased GFR, then the distal tubule would have less fluid flowing through it right here. The macula densa normally senses decreased urine volume by sensing decreased sodium and chloride in the urine. The macula densa cells then stimulate the release of renin from the juxtaglomerular cells. If there is less sodium and less chloride in the urine, the macula densa cells will sense this, thereby increasing signals to the juxtaglomerular cells to secrete renin, which then acts to correct the low fluid volume. Lastly, the juxtaglomerular cells have beta-1 receptors on them. So we'll just write beta-1. So a patient can have a sympathetic response and stimulate the juxtaglomerular cells to secrete renin. So I will draw a quick spinal cord right here with nervous tissue reaching the beta-1 receptor. And this stimulation increases the release of renin. So we know that renin release is increased by decreased blood flow through the afferent arteriole, as well as decreased sodium and chloride delivery to the macula densa, and renin is also released by sympathetic stimulation of the beta-1 receptors on the juxtaglomerular cells. Now let's focus on what renin actually does in the body. So the liver will release angiotensinogen And then the renin released from the juxtaglomerular cells will convert the angiotensinogen into angiotensin 1. And the angiotensin converting enzyme, ACE, which is released from the pulmonary vasculature, then converts angiotensin 1 into angiotensin 2. Angiotensin 2 then has several activities meant to counteract the low blood pressure sensed by the kidney. In other words, angiotensin 2 will increase blood pressure. And one of those activities is to stimulate the release of aldosterone. So let's focus first on angiotensin 2. So let's go back to the nephron. So here we have the glomerulus with the afferent arteriole and the efferent arteriole. Angiotensin 2 will constrict the efferent arteriole. Constriction of the efferent arteriole will increase the amount of plasma filtered by the glomerulus, which will increase GFR. Angiotensin 2 also acts on the proximal tubule to upregulate the sodium-hydrogen antiporter, as discussed in the first lecture on the nephron. So this will increase sodium and water reabsorption. Remember that water follows sodium. So increasing sodium reabsorption means increased water reabsorption. Upregulating the sodium-hydrogen antiporter would also mean more hydrogen would be secreted into the urine. And this would mean more bicarb reabsorption, which would of course increase serum pH. So going back, the initial decrease in blood pressure, or sympathetic stimulation, or decreased sodium chloride delivery to the macula densa caused increased release of renin, which then led to increased angiotensin 2. Angiotensin 2 then increased the GFR, increased the water reabsorption, and increased serum pH. Angiotensin 2 also upregulates the release of aldosterone from the adrenal glands. So I will draw the kidney here, adrenal gland here, and aldosterone causes the release of aldosterone from the zona glomerulosa. So I'll just write aldo. Aldosterone then acts on the principal cells to increase the reabsorption of sodium and the reabsorption of water, because water follows sodium. This increase in water reabsorption will lead to increased blood pressure. Aldosterone also acts on the alpha cells of the collecting duct to increase the secretion of acid into the urine and the reabsorption of bicarb. Of course, this will increase serum pH. Now let's do a question. Let's say a patient has hypertension. What would happen to the sodium chloride delivery to the macula densa? So draw sodium chloride. We'll draw some macula densa cells here in the distal tubule. So this patient has hypertension. So with increased blood pressure entering the afferent arteriole, GFR would increase because there would be more filtration. If GFR is increased and more sodium and chloride are being filtered from the blood to then reach the macula densa, then sodium and chloride that reaches the macula densa would be increased. The increased sodium and chloride will be sensed by the macula densa to inhibit its action. So there will be less stimulation of the macula densa to the juxtaglomerular cells. Juxtaglomerular cells right here, and if these cells normally secrete renin, then with decreased stimulation from the macula densa, renin release would be decreased. To extend the question, what would eventually happen to water reabsorption from the proximal convoluted tubule? Well, with decreased renin, there would be decreased angiotensin 2. And this would then downregulate the sodium-hydrogen antiporter on the proximal tubule, which normally secretes hydrogen and reabsorbs sodium. Thus, less sodium would be reabsorbed. And if less sodium is being reabsorbed, then less water would be reabsorbed, because water follows sodium. So let's do another question. Okay, so here is our juxtaglomerular apparatus again, and we have the afferent arteriole here, and the efferent arteriole here. Now, the question is, what would happen to the GFR and potassium concentration in a patient taking an ACE inhibitor? So we'll write GFR and serum potassium concentration. We'll recall that the angiotensin converting enzyme, ACE, is responsible for making angiotensin II. If there is an ACE inhibitor, ACE with lowercase I, this angiotensin converting enzyme will be blocked. Therefore, angiotensin II levels will be decreased. Recall that angiotensin II normally constricts the efferent arteriole, and the constriction of the efferent arteriole would then lead to increased filtration and increased GFR. If you have less angiotensin II, then you'll have less constriction of the efferent arteriole and therefore less filtration and decreased GFR. So that answers our first question. In a patient with an ACE inhibitor, GFR will be decreased. But what would happen to the potassium level? Well, with decreased angiotensin II, there would be less stimulation of the zona glomerulosa to release aldosterone. Aldosterone. Recall that aldosterone acts on the principal cells of the collecting duct to increase sodium reabsorption and potassium secretion. Aldosterone normally causes potassium secretion. So, low angiotensin II would mean low aldosterone, which would then mean low potassium secretion. And if potassium is not being secreted as much from the collecting duct, then more will be in the serum. So the serum concentration of potassium will be increased. Okay, so let's say there's a patient with chronic anxiety. What would happen to this patient's aldosterone level? Okay, recall that the juxtaglomerular cells, which I will draw right here, these have beta-1 receptors, which are sympathetic receptors. It's also important to know that anxiety and stress stimulate the sympathetic nervous system, as you've heard, fight or flight. So we'll draw a spinal cord real quick, and then some very simplified sympathetic fibers reaching this beta-1 receptor. So if a person is chronically anxious, then this sympathetic response will be heightened, and the juxtaglomerular cells will be stimulated to secrete more renin. And high renin, of course, leads to high aldosterone, which answers our question. So chronic anxiety can lead to high aldosterone. Now let's do another question. Let's say there's a patient with heart failure. What would happen to the renin-angiotensin-aldosterone system in this patient? So here we have renin-angiotensin-aldosterone system in a heart failure patient. Okay, well, if you have heart failure, you're going to have decreased cardiac output. And so that means there would be decreased blood flow or decreased blood pressure going through the afferent arteriole. So the juxtaglomerular cells would begin to secrete renin. And renin, of course, would lead to increased angiotensin II, which would lead to increased aldosterone. Another way to ask a question like this is to ask what would happen to fluid reabsorption from the nephron in a patient with heart failure. Well, increased angiotensin II and increased aldosterone would mean increased fluid reabsorption from the proximal tubule and collecting duct respectively. Therefore, a patient with heart failure would have increased fluid reabsorption from the nephron, so they would have increased volume. Okay, now let's move on to ADH. ADH is produced in the hypothalamus, but it is secreted from the posterior pituitary. And the stimulus for release is when the supraoptic nucleus of the hypothalamus senses increased serum osmolarity or hypovolemia. When ADH is released, it has two functions. It can act on the V2 receptors on the kidney to increase water reabsorption through the addition of aquaporins in the collecting duct. The other function is to stimulate V1 receptors on the blood vessels throughout the body to cause vasoconstriction. And this will, of course, increase blood pressure, which is an expected response in a patient with hypovolemia. And sometimes it's hard to keep V1 and V2 straight and know which belongs to which. So I remember it by simply thinking the body has two kidneys. So the kidneys must have the V2 receptors. And then, of course, the other one just belongs to blood vessels. Okay, so let's draw this out. So here we have the hypothalamus, where ADH is synthesized. Then we have the posterior pituitary, where ADH is actually secreted into the body. And here we have the kidneys, and there are two of them, so they must have the V2 receptors. And I will draw the blood vessels. And these ones have the V1 receptors. Okay, so now let's talk about what stimulates the release of ADH. As mentioned in the previous slide, increased serum osmolarity will stimulate the release of ADH. Another way to think of increased serum osmolarity is to think of having less water in the body. So the solutes are in higher concentration. In other words, the body is low in water. Another stimulus is hypovolemia. The body is low on fluid. So these stimuli, increased serum osmolarity and hypovolemia, will trigger the release of ADH. The question is then, how is the release of ADH triggered? Well, the hypothalamus has a supraoptic nucleus. I'll just write SO. This supraoptic nucleus senses these stimuli, which triggers the release of ADH from the posterior pituitary. So now the question is, what does ADH do in the body? Well, starting with the blood vessels, ADH will act on the V1 receptors to cause vasoconstriction. So we'll just show this blood vessel constricting. This vasoconstriction will cause increased blood pressure, and this is helpful in a patient with low body fluid. ADH also acts on the V2 receptors within the principal cells of the collecting duct, and this will increase water reabsorption. And increased water reabsorption will, of course, help increase blood pressure, which is helpful just like ADH was on the blood vessels causing vasoconstriction. But increased water reabsorption will also help correct the increased serum osmolarity by bringing down the osmolarity of the serum, and then it will also help add fluid, which helps correct the hypovolemia. Okay, so let's do a question. What would happen to the supraoptic nucleus receptors in a patient with psychogenic polydipsia? So psychogenic polydipsia, also called primary polydipsia, means the patient is drinking massive amounts of water as a result of a psychological condition. Okay, so the patient is drinking lots of water. And so what would this do to the osmolarity? Well, the serum osmolarity would actually be very low. It's very dilute. And therefore, the supraoptic nucleus on the hypothalamus, we'll draw the supraoptic nucleus. This supraoptic nucleus would be less stimulated. So less ADH would be released from the posterior pituitary. So ADH secretion would be decreased. Now let's talk about autoregulation. So let's draw a picture to depict this. So we've got the glomerulus and the arterioles, and then we'll just draw part of the nephron. So we're talking about autoregulation. And what this means is that the kidneys are able to maintain a normal renal blood flow through a range of perfusion pressures. In other words, blood pressure coming into the kidney can be on the lower side, so we'll write lower blood pressure, but the kidneys can increase the pressure throughout their own vasculature to maintain a normal blood flow. The pressure may even be on the higher side, so we'll draw higher blood pressure coming into the kidneys, but the kidneys can again respond to that to establish a normal renal blood flow. So there are two ways the kidneys do this autoregulation of blood flow. First is through a myogenic response. This simply means stretch of the afferent arterioles, which means there's stretching of these afferent arterioles. So when they are stretched, when the pressure is high, they will reflexively constrict, constricting the afferent arterioles. Recall that if the afferent arteriole is constricted, the GFR will be decreased. Decreased GFR. This constriction of the afferent arteriole will attempt to decrease the flow through the vasculature, keeping the renal plasma flow to a normal level. This will also act to decrease the GFR, keeping it at a normal level. So the second mechanism of autoregulation is tubuloglomerular feedback. To demonstrate this, we will actually need a distal convoluted tubule to go through the juxtaglomerular apparatus, because the DCT has the macula densa cells. So tubuloglomerular feedback simply means that if GFR is increased due to increased perfusion pressure through the glomerulus, so we have increased filtration, increased GFR. If GFR is increased, then more fluid would be reaching the macula densa, which means you'll have increased sodium and chloride for the macula densa to sense. If the macula densa senses increased sodium and chloride, there will be less signal to the juxtaglomerular apparatus to release renin. So renin would be decreased as a result of the increased flow. And as we discussed earlier in this lecture, decreased renin will lead to decreased angiotensin II. Angiotensin II normally constricts the efferent arteriole in order to increase GFR. But with decreased angiotensin II, there will be a relative dilation of the efferent arteriole. And this will act to decrease GFR. So to summarize tubuloglomerular feedback, the increased GFR will increase the fluid flow through the macula densa in order to decrease renin and angiotensin II. Low angiotensin II will decrease GFR to a normal level. So let's do a practice question to apply this. So the question is, in a patient with new hyperaldosteronism, what would happen to the tubular glomerular feedback? Okay, so now let's say that the cause of the hyperaldosteronism is an aldosterone-secreting tumor from the adrenal gland. In any case, the patient has high aldosterone being secreted into the serum. With this high aldosterone, the patient would be reabsorbing a lot of isotonic fluid from the collecting duct due to increased sodium and water reabsorption. So we'll write sodium and water. As a result of this increased water reabsorption, the patient would develop increased blood pressure. This increased blood pressure would mean increased blood flowing through the glomerulus, which would mean more urine. Therefore, there would be more delivery of sodium and chloride to the macula densa, which is around this region. The increased fluid flow to the macula densa would cause it to decrease its paracrine signaling to the juxtaglomerular cells. Thus, renin secretion would decrease. In other words, tubuloglomerular feedback from the macula densa to the juxtaglomerular cells would decrease in a patient with hyperaldosteronism. And this helps the kidneys maintain a normal GFR during a state of high aldosterone. Okay, so here's another question. What would happen to the GFR in a patient with renal artery stenosis? Okay, so let's draw a kidney really quick. We've got the renal artery leading into the kidney. And if this artery was stenotic, so we'll draw the stenosis here, then there would be decreased blood flow to the kidney. A decreased blood flow would mean decreased filtration of the plasma and therefore decreased GFR. To extend the question, what would happen to the renin-angiotensin-aldosterone system in a patient with decreased GFR? We'll write the question right here. So this patient has decreased GFR. So what would happen to the renin-angiotensin-aldosterone system as a result? Well, decreased GFR would mean decreased urine flow to the macula densa. So we'll write decreased flow to the macula densa. So we'll just write MD for short. And this decreased flow to the macula densa would cause them to stimulate the juxtaglomerular cells, JG cells, to secrete renin. So renin would be increased. So in answer to our question, in a patient with decreased GFR, the renin-angiotensin-aldosterone system would increase. Now this particular patient had renal artery stenosis. However, it's important to recognize that this constellation of findings can be found in any condition that decreases blood flow to the kidneys. For example, if a patient was severely dehydrated, there would be less blood flow through the renal artery. So I'll just write decreased blood pressure. So this condition would likewise cause decreased GFR and increase renin and stimulate the renin-angiotensin-aldosterone system. So let's say there's a patient taking loop diuretics. What would the loop diuretics cause to happen with the renin-angiotensin-aldosterone system and why? Okay, so here we have the nephron in this sketch here, and we have the thick ascending limb in this region. And the thick ascending limb has a sodium potassium chloride cotransporter. Now a loop diuretic will actually block this channel so that sodium, potassium, and chloride will stay in the urine. So this initially would cause an increase in the sodium and chloride reaching the macula densa. So this would cause a decrease in renin. However, the loss of sodium in the urine would mean that there is a loss of water as well, because water follows sodium. So there's more to know about how loop diuretics affect the function of the nephron, but this is discussed in part 2 of the nephron section of this chapter, section 3. For now, it's just important to know that with this water loss, the patient eventually loses enough water that flow through the glomerulus actually decreases, and therefore GFR decreases. And this decreased GFR means that there would be less fluid flow and urine flowing to the macula densa, so that sodium chloride delivery would be decreased. Therefore, renin secretion would actually be increased. There would be more stimulation of the juxtaglomerular cells to secrete renin. In summary, loop diuretics cause enough water loss that the renin-angiotensin-aldosterone system will be stimulated. And this concludes our section on renal endocrinology.